Hello, we're back with part two of four of the human body. The human body has three types of muscle that comes with our body. We have skeletal muscle, also known as voluntary muscle. We have cardiac muscle, which is a special type of muscle. And then we have smooth muscle. We'll first talk about our skeletal muscle, or also known as voluntary muscle. It attaches to bones and it forms the major muscle mass of the body and is responsible for movement and is under conscious control. Hence the name voluntary. It allows us to move. We can move or we can stop this muscle from moving. So it's known as a voluntary muscle. Next, we have our smooth muscle. The smooth muscle is found in the GI tract, urinary tract system, and blood vessels. It's also found in the lungs. It contains blood vessels, and it's also in the urinary system. And it controls this smooth muscle or involuntary muscle, controls the flow of materials through these structures. These muscles respond to the brain, but are not under voluntary conscious control. And these particular muscles will respond to heat and cold and stretching. Now, one of the things about this, it's found in the urinary tract and the gastrointestinal tract. And are also found in the blood vessels, helping to control flow through these materials. And you have no conscious control over these smooth or involuntary muscles. So what happens is, think about this. All of a sudden, you've got this gurgling in your stomach. You don't think much about it. You're going, well, shoot, I can hold out a little bit longer before I have to go to the bathroom. And then all of a sudden, the smooth muscle or the involuntary muscle goes, you know what? I'm tired of waiting around. I'm going to go, and I don't care where the owner is of all this, but I'm going to go. And you can try to hold on to it as much as you can for as long as you can, but you cannot consciously control involuntary smooth muscle. Because when it's time to go, Katie, bar the door, you're going to go. You can't stop it. Hence, involuntary muscle, the smooth muscle. Then we have our cardiac muscle. Cardiac muscle is only found in the heart, and it is a special form of smooth muscle. It's a specialized form of an involuntary muscle. It's extremely sensitive to hypoxia, meaning decreased oxygen supply, and can only tolerate a very short period of time of interrupted blood flow because it has its own blood supply through the coronary arteries. The heart muscle itself is supplied with blood through the coronary arteries. The other unique thing about cardiac muscle is it has a unique characteristic. It has a property that is called automaticity. Automaticity meaning that the heart has the ability to generate and conduct electrical impulses on its own. The heart then can contract on its own because it has its own electrical stimulus. Think of the automaticity as if you take it to the idea of an automobile that has a battery and it has an alternator. Now, the battery stays charged because of the alternator. Well, if the battery starts going bad, the alternator will kick in to let your car start. You go da da da, and it won't start, da, 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 and then all of a sudden it catches and starts. It's because of that alternator. Once that alternator gets going, that battery will get recharged. Same happens with the automaticity. If the heart stops beating, the electrical impulse of the cardiac muscle can actually start that heart muscle back in. If it skips a beat, we're not supposed to skip heartbeats, but if one gets skipped, that automaticity kicks in to get it back to a regular rhythm. So just like the alternator will only recharge that battery for so long, and then you have to buy a new alternator and a new battery, which is a whole lot easier to purchase than a whole new heart. So the alternator helps jumpstart the battery when it's bad. The automaticity of the heart helps to jumpstart the heart. If it stops, it kicks in. The person has extreme chest pain, has had possible heart attack, calls you. They're still talking to you. Their heart's working again, but there's only so many restarts of the heart muscle with this automaticity. But that's what makes this cardiac muscle an involuntary muscle and has its own special properties known as automaticity. It's able to generate an electrical impulse to restart the heart. Now we're going to talk about the respiratory system. The respiratory system consists of the nose, the mouth, the pharynx, the larynx, the trachea, the bronchi, the bronchioles, and the alveoli. The nose and the pharynx serve to warm and humidify the air that we breathe in. The air, when it enters the nose, proceeds through the nasal pharynx, where it enters, and if it enters through the mouth, it proceeds through the oral pharynx. The area of the oral pharynx is also known as the hypopharynx. It's where the pharynx and the oral pharynx come together at the back of the throat. It's also known as the hypopharynx. The epiglottis is a leaf-like structure which closes over the glottic opening anytime we eat to prevent us from choking on that food and to keep the food from going down into the lungs. And it allows for airflow through the larynx or voice box and into the trachea. Trachea leading down to the lungs. The trachea, or the windpipe, is the tube that carries air into the lungs. The cricoid ring is a solid ring that forms over the lower portion of the trachea, and it's the only cartilage of the trachea that is completely round. And you can feel that where the little bump is in your throat area. It continues, the trachea continues on down to where the trachea splits into two branches known as bronchi, which then branch into the bronchioles, which then terminates in the alveoli. The alveoli is the furthest part of the lungs where gases and air exchange. The alveoli are very small little sacs where the gas exchange takes place. And the alveoli, they're very elastic. They get bigger when we breathe in and they get smaller when we breathe out. We have millions of these alveoli in the lungs. Continuing with the respiratory system, the purpose of the respiratory system is to move oxygen in and carbon dioxide out of our body. When we inhale, we move oxygen into the bloodstream. When we exhale, carbon dioxide is excreted through our exhalation. The cells of our body need oxygen to function, but also need to get rid of the waste product, which is known as CO2. Getting rid of too much CO2 can be a bad thing. This is why we don't hyperventilate our patients any longer at 40 times a minute, because what we were doing was we were not giving adequate time for the CO2 to expel from the body. We'd be bagging at 40, 42, 48 times a minute, thinking we were doing good for our patient. And in the long run, we were doing bad for our patient because we were increasing their carbon dioxide by not letting it out, and we weren't giving them any oxygen to the blood. So what is our stimulus to breathe? Too little oxygen? No. Too much CO2. The stimulus for us to breathe is our buildup of CO2, and then we get rid of that CO2. If you were to hold your breath for as long as you could, the buildup of the CO2 not being able to get out is what our stimulus is to breathe. The buildup of the CO2 gets too high, and all of a sudden you got to blow that CO2 off to get oxygen in. The oxygen and CO2 have to exchange on a constant pattern. So our stimulus to breathe is actually the buildup of too much CO2. I have a couple of terminologies. Inhalation, also known as inspiration, is an active process. We have to actively breathe in and out. The intercostal muscles, remember, intercostal muscles are the muscles of breathing that are in between the ribs. The ribs, also known as costals, intercostal muscles, allows the ribs to move up and out and the diaphragm to move down. Intercostal muscles move the ribs up and out. Think of inhalation, getting the chest bigger, and outward, And the diaphragm, which is our major muscle of breathing, it moves downward. So what this does is it expands the cavity and allows air to be drawn in and flow in because of the pressure changes. So the diaphragm and intercostal muscles contract, the diaphragm moves down, the ribs move upward and outward, and the size of the chest increases. That's why if you see a bodybuilder, when they're flexing, they want to take a big breath of air in to make that chest look even bigger than what it really is. Here we have a picture of inhalation, air flowing into the lungs. The intercostal muscles and the diaphragm contract to move the ribs up and out and the diaphragm down. So when we breathe in, the diaphragm goes down. We breathe out, the diaphragm goes up. On the other side, we have exhalation or expiration. Expiration is a passive process, meaning you can hold your breath, but eventually you're going to have to inhale or exhale, the air out. Exhalation or expiration is a passive process. You don't have to work to exhale. It's going to happen automatically because of the buildup. The intercostal muscles relax, the ribs lower, the diaphragm relaxes, it moves upward to its normal resting position. The size of the chest cavity decreases and air flows out and is compressed out by the decreasing cavity size. So exhalation, the lungs are full, the diaphragm moves upward and upward, the ribs move lower, and the air flows out. Exhalation, air flowing out of the lungs. Now this particular slide shows to play, but it never has played. I don't know why. I guess it's because it didn't stay up with the updates of all the computers. But gas exchange, the oxygen and carbon dioxide is exchanged in the alveoli and tissues of the body. Here you have a picture of the alveoli. They look like little sacks of grapes, best way to explain it. Oxygen enters the alveoli during inhalation. The CO2 arrives at the capillaries that surround the alveoli, and the CO2 is released and crosses into the alveoli, and oxygen is taken up by the red blood cells and whisked off to all the other cells of the body. Talk a little bit about adequate breathing. It's not enough to determine if your patient's breathing. We must figure out if the patient is breathing adequately or inadequately. Right now, we're talking about adequately. So what is adequate? Is the patient's rate and depth normal or appropriate for what's going on? You take an elite athlete such as just off the top of my head, Michael Phelps, world-class swimmer. Adequate breathing to him at night when he's sleeping could be 4 times a minute, but he has such good tidal volume that he's able to survive on that. So adequate breathing, you have to look at your patient and determine if they're adequately breathing. If you were to take off and run around the block 20 times as fast as you could and come back, would you be breathing greater than probably 12 to 20 times a minute? Sure. But are you breathing adequately? It would appear that you're not breathing adequately, but the key there is, does your breathing come back to normal in a short amount of time? You might be breathing faster than 20 times a minute because you just got done running around. It's what we look at when we're saying, are they adequately breathing? Are they breathing the rate and depth? Is it appropriate for the situation? Do you hear regular lung sounds? What do they sound like? When we're breathing in and out normally, there's no noise that is associated with breathing. But if you hear noisy breathing, that would be considered inadequate breathing. But adequately, there's no abnormal breath sounds. We need to look at our patient, and does the air move in and out of their chest freely? Or does your patient have to work at breathing, work at getting air in, work at getting air out? So is the air moving freely in and out of the chest? And is the skin color normal? The patient's skin should be warm, dry, and pink, not blue, not ashen. Now, with that said, warm, dry, and pink, dark skin patients, if you look at their palms of their hands, have pink color to them. So we can check dark skin patients. We check their palms to see if they are pink. Is their skin warm and dry? And are their palms of their hands pink versus blue or ashen, which is a gray color, which are signs of inadequate breathing? Adequate breathing, our normal rates for the adults are 12 to 20. They can go upwards of 24 times a minute. The national looks doesn't really ask for strict numbers, such as adults 12 to 20. What they would do if they were asking a question, they would say adequate respirations of the adult are between 8 and say 24 times a minute, which would be adequate, because you can breathe 8 times a minute and that's adequate, and you can breathe 24 times a minute and that's adequate. American Heart Association says 12 to 20 times a minute. National will give a range using 8 and 24 times a minute. So would between 8 and 36 times a minute be adequate? No, not according to National Registry, because they're saying 8 to 24, but if they say 12 to 20, that's within the range of 8 to 24. And if you have a question on that, you can email me, wait till our next FaceTime, and ask that question, and I'll explain that even more, and it might make a little more sense. Children, 15 to 30. Infants, 25 to 50. About the infants, we don't want them to breathe more than 60 times a minute. 60 times or greater in an infant is an infant that is going into respiratory failure. Their little body cannot, their muscles cannot maintain that type of breathing for very long. So they're on early side of respiratory failure. Newborns should be somewhere between 30 and 60 times a minute, but never over 60 times a minute. Newborns, infants, should never be over 50 times a minute. Or 60 times a minute. So one of the easy ways to remember, infants' low end should be double the adult's high end. Their low end should be roughly double the adult's high end. Those are adequate breathing. Now let's talk about some inadequate breathing. So how do you recognize inadequate breathing? They may have some breathing effort, but not enough to live. They're making an attempt, but they're only breathing 2 or 3 times a minute. That's not enough to sustain life. Now, I used Michael Phelps as a person that can breathe 4 times a minute and live happy. He sleep, but he gets such tidal volume in there that he can breathe 4 times a minute. Inadequate. Look at your patient. Do they look good? Do they look bad? They're breathing, but they're breathing 4 times a minute. Is that adequate for what they look like? Another way, rate and depth outside of normal limits. Are they breathing too fast? Are they breathing too slow? Are they breathing very shallow? Or are they taking long, deep breaths? Do they have a decreased minute volume? Meaning how much volume are they getting into them in 1 minute? They're breathing 36, 40 times a minute. They're not getting enough volume in, but they're breathing that 12 to 20 times a minute. They're most likely getting adequate volume in with each breath. You look at their skin. Do you see that they're pale or they're blue, also known as cyanotic? Or are they ashen? Ashen is a gray color. Think of the gray of a t-shirt that you might wear at the gym or something. It's that look of, wow, they don't look good. And I challenge you as we start going through this, and when you're out, start observing people more so than you do. And I'm not talking about observing, observe them. Do they look good? Do they look bad? We're not talking, yeah, they're really good looking or they're really ugly. Not that bad good. Look at how they are handling themselves. Do you see somebody walking with an oxygen tank behind them, pulling it? Chances are that they won't look like they feel good. because they're having to carry their own oxygen supply because they don't breathe adequately. So start looking at patients. Don't stare or at people. Don't stare at them, but look at them and just kind of get an idea. Do they look like they're look good? Do they look bad? Now, with COVID, might be a little tough because a lot of people have a mask on. But you can still kind of look at their skin and get an idea if they're. A lot of people don't like having something cover their mouth and their nose at the same time, but this is a unique time in life that it could be the difference between being sick and being healthy. So just start looking at people and kind of debating whether they look good, do they look bad, do they look healthy or not healthy. And then their skin, inadequate breathing, you feel they have cool skin, clammy skin, which is kind of that moist, sticky skin, when they shouldn't have moist, sticky skin. So cool and clammy skin. Some inadequate breathing, shallow or agonal respirations. Shallow meaning breathing quick, not getting good exchange, just shallow breathing. Agonal respirations are the occasional gasping type of breathing seen just before death, also known as fish breathing. Those of y'all that go fishing, you get the fish out of water and you see him trying to get air, kind of that gasping look, kind of a fish breathing. It's that occasional gasping for air. Do they have diminished or absent breath sounds? Diminished breath sounds, meaning when you're checking their lungs with your stethoscope, they're hard to hear. They're diminished. Or maybe they have sounds when they're breathing, such as wheezing or snoring. If you walk into a patient's house to do your patient assessment and you hear them snoring, are they asleep? If they're snoring, yeah, they might be asleep, but they might be unconscious. And what has happened is the tongue has fallen back against the throat, which is now obstructing the airway, and that's where the snoring sounds come from. Worse yet, diminished or absent breathing, noisy breathing such as crowing, stridor, snoring, gurgling, gasping for air. Think about if you ever been punched in the stomach as a kid and you were gasping for some air. You might get called on a patient that's gasping, having difficulty breathing, and you get there and they're gasping for air. Or worse yet, no breathing sounds, no breath sounds. You can't hear any breath sounds. They have a quiet chest. That's not good. And you need to be able to identify inadequate breathing quickly and try to fix the inadequate breathing quickly. Increased use of accessory muscles, especially in infant and children, using their intercostal muscles. They're using the accessory muscles of the neck, the nasal. The pediatrics may have nasal flaring, or they may be grunting to breathe. When you hear a pediatric child grunting to breathe, they are already in respiratory distress. They are going to go further down quickly. gasp or grunting breaths is a very, very bad sign of inadequate breathing. Here you have some signs of inadequate breathing. Going down the left side, nasal flaring. We see that a lot more in the infant and children than we do in adults, but we can see nasal flaring occasionally. Cyanosis. Remember cyanosis being kind of a bluish hue to the mucous membranes around the oral cavity area there, the lips, nose, the skin. They may complain of chest tightness. Look for excessive use of accessory muscles. People may tell you they have numbness and tingling in their hands and feet. Numbness and tingling in their hands and feet is a sign of inadequate breathing known as hyperventilation. They're overbreathing. They're breathing 36, 38, 40, 42 times a minute. Once again, they're breathing that fast, they're not getting good volume exchange. They may have pursed lips on inhalation, trying to work to breathe in. They may have coughing, crowing, high-pitched bark. They may have respiratory noises such as wheezing and rattling. Listen with your stethoscope to breath sounds. Impaired mentation. They may go unconscious. They may complain of dizziness, restlessness. Restlessness is a sign of inadequate breathing because there's not enough oxygen getting to the brain. Anxiety, confusion, combativeness. Try to find the problem with the difficulty breathing to fix the problem. Talk a little bit about the pediatric anatomy, airway anatomy. Their airway structures are smaller and more easily obstructed. The tongue of the pediatric patient is proportionately larger than an adult's, meaning their mouth, their tongue takes up more space in their mouth than our tongue does as an adult. The trachea is narrower than the adults and more easily obstructed. Their trachea, as a pediatric, as a newborn, is about the size of their pinky finger. So the trachea is narrower than the adults and more easily obstructed, and it's softer and more flexible than the adult trachea. That's why we don't ever use cricoid pressure on the pediatric airway, because we could actually collapse their trachea to where they don't have any airway exchange. The pediatric chest, their airway, their chest area are softer, and breathing depends on the diaphragm itself for that pediatric patient to breathe and to breathe adequately. Here we have a picture of the pediatric airway anatomy. Their cricoid their cricoid cartilage is not well developed. It's less rigid. The chest wall is softer, and infants are abdominal breathers. They're known abdominal breathers. The chest walls are softer, and their breathing depends on the diaphragm, and this makes them known as belly breathers, because it makes it look like their belly's doing more breathing. Some signs of inadequate breathing. Signs are something that you would see. We have signs and symptoms. Signs being something you can see. Symptoms are something that the patient tells you. So inadequate breathing in infant and children. Nasal flaring. You'll see their little nostrils flare out trying to breathe in. Retractions. They're working hard to breathe. The retractions are from the intercostal muscle use, but you got to remember the infants and children, their intercostal muscles are not as well developed as the adult. Seesaw breathing. This is where it gives the appearance that the belly goes up, then the belly goes down, and the chest goes up. It's not actually doing that. Well, it is doing that, but they're working so hard to breathe that this seesaw breathing is created because of the retractions with the intercostal muscles that are not fully developed. They're using accessory muscles to breathe, so that's where our intercostal muscle retractions come from. And the belly breathing, being in a seesaw motion, the chest and the abdomen will alternate movement. And those are distinct signs of inadequate breathing in children. So this is the end of part 2 of 4 parts of the human body.